Hello, everyone. Today, we'd be discussing this research that was conducted by Christina Brudvik in the year 2016. Now, this particular research, this is a recent addition to our syllabus and that changed in 2024. About this particular study, this is a key study, and as you all must be aware that these key studies, they are not only very important when it comes to paper 3, but they are also very important when it comes to paper 4 as well. For paper 3, we have had, if we have a look at the specimen paper, we have had a 6-mark question on a key study. So if so that in other words means this could possibly be the next key study that you get a question on as well. And when we talk about these 6-mark descriptive questions, remember these 6-mark descriptive questions are followed by a 10-mark evaluative question as well. So that's a chunk of 16 marks out of 60 that could possibly that you could possibly be tested on in paper 3 on a particular key study. Now, about paper 4, in paper 4, you could be asked about the different aspects of a key study as well. So I could go on and on and on, but I'd like to start off with this uh, study so that it doesn't really take us very long to complete it. Now, when we talk about this particular study, this is, like I said, this comes under the unit pain, and this study is about the extent to which doctors or physicians or practitioners they'd be able to diagnose the levels of pain their patients are experiencing. Specifically, it is about the extent to which physicians are able to diagnose the levels of pain that their child patients or children experience, right? When it comes to an outpatient setting, or in other words, when it comes to these children's being brought to an emergency room at a hospital, at any particular medical facility, right? So this study, like I said, it is about the comparison. This study is about the comparison in terms of pain assessment, right? A comparison in terms of pain assessment, a comparison between the child, that is the patient, the child's parent, because for a young child, of course, the child would be accompanied by the parent. It's highly likely that the child would be accompanied by the parent when he or she is brought into an emergency room, and the physician. Now, it's pretty essential that the physicians diagnose this pain or are able to assess this pain well, because if they're not, then they would then the healing might delay, or the relief that the child is expecting might delay as well. And this could be a short-term consequence. However, in the longer run, the child might develop an anxiety, the child might develop a fear towards the medical system as well. So taking this ahead, I'd quickly want to show you how the syllabus looks like. I have the screenshot from the syllabus in front of you just to show you how a particular unit, a particular typical unit is structured. This is a unit from health psychology. When I use the word unit, I'm actually referring to a chapter over here, right? So every unit, as you see, is divided into 3 different sections. And if you have a closer look, you'd be able to see the key study over here. Here you go. So this is what I'm talking about. This, right? Now, taking this ahead, if we how is it that I plan on explaining this to you? I'd initially start off with the context. We'd move on and we'd speak about the main theories and explanation. We'd move on towards the aim, 3 different aims. We'd discuss the study sample, the study design, and the results. Now, it's pretty essential that we understand a research well to be able to evaluate it, right? We cannot really evaluate a particular study without understanding it well. So without any further ado, let's start off with the context of this particular research. Research shows that children often don't get enough pain relief in healthcare, especially in places like the emergency room. They may not receive pain medication often enough, or there may be delays in giving it, right? So it might not be enough, as in a particular dose being given to a child. The dosage that is given to a child has a lot to do with the extent to which the physician assesses the level of pain, right? And this could also result in delays in giving it, right? Or these doses might be too low. This lack of proper pain management, it wouldn't be wrong to if it wouldn't be wrong if we refer to this as a lack of proper pain management, can lead to short-term issues like slower healing and long-term problems like anxiety about the medical care or the healthcare system. The reasons for this might include: number one, time constraints; number two, concerns about the productivity; number three, hesitancy to give children pain medication due to potential side effects. So these could be the reasons behind, these could be the possible reasons amongst many, as to why physicians might not be able to manage pain for their children patient, for the child who's come up as a patient. Now, if you have a look at the main theories and explanation for this particular study, number one, pain is a highly subjective experience. Now, what do I mean when I say pain is a highly subjective experience? Now, for instance, if we're talking about three individuals over here, let's name them A, B, and C. If it is very painful for patient A, it might be there's a possibility that the same level of pain might not be seen as very painful for patient B. And so would be the case for, so could possibly be the case for patient C as well. So when we talk about pain, pain is a highly subjective experience, varying from person to person. This means that individuals have different pain thresholds. Now, when I say individuals have different pain thresholds, what do I mean? The extent to which someone can tolerate pain, the extent to which someone can bear pain, is it varies from person to person. For children, assessing pain can be challenging. Of course, children, again, depending on the age and the communication skills of the particular child or the severity of the pain that the child is encountering, it might be a very challenging process. So for children, assessing pain can be challenging because many traditional methods may not be suitable or understandable to them. However, there are certain specialized pain scales that are designed for children that can help assess their pain levels accurately, or rather say relatively accurately. Research suggests that parents and healthcare providers often underestimate the pain experienced by children. So, this could possibly be the reason as to why this research was conducted by Dr. Christina Brudvik. Now, Dr. Christina Brudvik, she's a medical doctor and a professor at the University of Bergen in Norway. Now, taking this ahead, research suggests that parents and healthcare providers often underestimate the pain experienced by children. Studies have shown that children themselves report high levels of pain compared to assessment made by adults. Additionally, in cases of chronic illnesses, children's reports of their quality of life can differ from those of their doctors and parents. Now, we're actually referring to a discrepancy over here. The discrepancy in terms of how a child patient assesses his or her pain or sees his or her quality of life as compared to how their parent would do that, and as compared to how the physician or the doctor would do that, right? Now, taking this ahead, let's quickly move on towards the aims that we have for this particular study. Now, for the sake of better understanding, I have divided this into three different parts. Now, I haven't really divided this into three different parts. I have, or rather say, put this into three different headings so that you all could understand this better. Number one, we'd speak about the first aim over here deals with the level of agreement. The first aim over here deals with the level of agreement. The second one deals with certain factors that could influence the diagnosis. And the third one, the impact on pain relief. Now, to begin with the first one over here, the first aim, the study aims to determine how closely the assessments of pain intensity align the between children, number one; number two, the parents; number three, the physicians, as I'd mentioned when we were reading through the title of the study. This involves comparing the ratings each group gives for the same pain experience, right? Now, we're talking about a comparison between in terms of ratings. When I use the word ratings, the first thing that occurs to me is quantitative data. Quantitative data. Quantitative data is better. It's easier when it comes to comparisons as well. So the first aim over here is to see is to try to figure out, or is to try to assess the level of agreement children, that is the patient, their parent, and the physician hold when it comes to the intensity of pain. One. Number two, Influencing factors. The study seeks to identify how factors such as the child's age, now we're talking about different factors here. Number one, the child's age. Number two, the child's medical condition and the severity of pain influence the differences in pain assessments provided by the children, parent, and physicians. Now, we're talking about some external factors over here that might as well include age. Now, for instance, uh would the rating for pain be the same by a 5-year-old child compared to a 10-year-old child or a 15-year-old child, right? And the medical condition. So the second aim over here, the study seeks to identify how far factors such as the child's age, the child's medical condition, and the severity of pain influence the differences in pain assessments provided. Let's watch. Okay, so provided by children, parents, and physicians. This analysis can help understand the variables that affect perceptions of pain. Now, by analyzing these different factors, we'd be in a better position to be able to understand the variables that affect the perceptions we hold about pain, right? Now, taking this ahead, the third aim, impact on pain relief. The study, now remember, impact on pain relief. Let me remind you all, if a physician is not able to diagnose pain well, this is of course going to affect if affect as well as delay the relief the patient holds. And in this case, when I'm using the word patient, I'm actually referring to children. So impact on pain relief. This study intends to examine how the pain assessment made by children, parent, and physicians influence the administration of pain relief by physicians. This could reveal whether discrepancies in pain assessment affect the treatment decisions made by healthcare providers. So a discrepancy between this, a discrepancy between assessment by this, and by this, right? Taking this ahead, I hope you've all understood all three of the aims real well. Taking this a step further, let's move on and talk about the sample that was used over here. Now, the sample over here comprised of 243 children with the average age they had was 3.15 years, right? So we're talking about 243 children. The average age was 3.15. Now I have put the sample in 2 points over here so that you all memorize it. Number one, you understand it well. Number two, you memorize it well. After you're done understanding and memorizing, then you'd probably be in a better position to evaluate this particular study, or for the matter of fact, any other study better too. So the sample comprised of 243 children. If we speak about gender distribution, 53% of the sample was boys, and that makes it 47% being girls. Now, if we talk about the setting, the study took place in Norwegian emergency department for over 17 days. So data was collected for over 17 days, right? So where was the study conducted? The study was conducted at a Norwegian emergency department. Remember when I said Dr. Christina Brudvik, she is a medical doctor and a professor at the University of Bergen in Norway, right? Now, then you guys won't be tested on this, of course. Now, the next thing, the participants were children, one, the parents, and the treating physicians who completed the questionnaire. So we're talking about questionnaires being completed as well. Let me remind you all real quick. Questionnaires are an example of a self-report measure. So using a self-report measure has its own pros and cons too. The next thing, physicians information. There was if you speak about the information that was if I let me uh walk you through a bit of information about these physicians too. So there were 51 physicians who participated. 57% of them were men, and again, 57% of them were men, 43% of them were women. 51% had their children. So we're talking about physicians having their own children, probably because you want to see if they could empathize well, right? 50% had over 5 years of experience, and 30% specialized in family medicine. However, none was a specialist when it came to pediatrics, or we did not have any pediatrician specialists over here, right? So, a bit of information about these physicians. There were 51. Let's number them. I think that would be easier for you to keep a check when you are memorizing the study. So 51 physicians participated over here, 57% of them were men, 51% had children, 50% had over 5 years of experience, and 30% specialized in family medicine. However, none of them was pediatrics. Now, a typical question asked at this point is, do we need to memorize all of this? I personally think yes, you should. Again, that depends on the grade that you have in your mind, the grade that you're actually working for, right? Now, uh, yeah, memorizing these numbers or quantitative data, uh, I believe is essential, especially when it comes to a case study, because you could get, and you have had a direct question on a key study in the specimen paper as well. So I'd strongly advise you to not miss on this. Now, taking this ahead, if we talk about the study design over here. Now, when we speak about study design, we had I'd like to divide the study design into two parts: pain assessment measures, and number two, we'd speak about questionnaires, right? Let me walk you through pain assessment measures first, and then we move on towards questionnaires. There are three different scales that would be used over here, and I'd want you all to get yourself familiarized with them. So the first one we deal with, or the first one we talk about over here, is the face pain rating scale, right? The face pain rating scale. This is the revised edition, right? The one at the bottom right, right? The second scale that we would be using over here is the colored analog scale. Learn this as well. And the third scale we'd use over here would be the visual analog scale, right? So we're talking about three different scales being used over here: number one, number two, and number three, right? So let's learn it together. The face pain rating scale, right? Face pain rating scale. Let me just show this to you. You might as well use FPS-R for this, right? R is for revised, right? Number two, we'd speak about the colored analog scale, that is CAS. This is what I'm talking about. And number three, we'd speak about the visual analog scale. This is again the visual analog scale over here, right? So there are three scales that we would be referring to over here. Now, what exactly is the faces pain rating scale, that is FPSR? Now, this is a pain rating scale that is suitable for children, that would be used by, remember, if you, let me take you back to the sample. The sample over here comprised of 243 children, right? 243 children, and their age ranged from, if I talk about the age range over here, from 3 years to 15 years, right? So what we have done over here is, what the researchers rather did was, they divided these kids into two different categories. The first category was kids from 3 to 8 years, and the second category comprised of kids from 9 to 15 years. And the researchers made these different kids go through different, or they made them assess the levels of pain through different pain scales, right? For obvious reasons, of course. If you talk in terms of the level of comprehension that kids between the age bracket 3 to 8 years would have, compared to the level of comprehension kids from the age bracket 9 to 15 years would have, would be different, right? So these were the scales that I'm talking about. This one, let me pick up another color for this. So children aged 3 to 8 years, they they use the FPSR scale. This is a pain rating scale that is suitable for children aged 3 to 8 years, showing six faces in an increasing level of pain. This is what I'm talking about. These six faces: one, two, three, four, five, six. And if you have a closer look at this, where zero means not hurt, no hurt, and 10 is the other extreme, that is, it hurts a lot, right? Now, if we move on and we speak about the colors analog scale, and this was used by kids between the age bracket 9 to 15 years, right? Now, The colored analog scale, this is the pain rating scale that was suitable, that was seen to be suitable for kids between the age bracket 9 to 15 years. They were respondents who marked on a line. Now, if you have a look, this is a line over here, right? So they marked on a line where the pain was from no pain, that is in the color green, through to worst thinkable pain, that is red. So all the way from here to here. Get it? Now, and along with this, the visual analog scale was used as well, which we have studied about earlier. So children between the age bracket 9 to 15 years, they use visual analog scale and the colored analog scale to be able to mark pain from no pain to the worst thinkable pain. However, remember there were three different categories of participants in this particular study. We had children, that is the patient, one. Number two, we had their parents, the patient's parents, right? And number three, the physician, right? So if we speak about parents and physicians, for them, there was a numeric rating scale referred to as NRS that estimated pain from 0 to 10. A lot of quantitative data being gathered over here, right? Now, I hope you've all understood these three different scales that were used. Actually, four. The first one being the faces pain rating scale, the revised version. The second one being the colored analog scale. The third one being the visual analog scale. And the fourth one, the numeric rating scale. And this was the one that was used by adults, parents, and physicians, both being adults. Having a look at the questionnaires, parents' questionnaires gathered demographic information. One, physicians provided information about their medical experience, about their specialty, and if they had children. One, two, third, right? Let me take you back to show you this part. Remember, we had discussed all of this over here under the study sample as well. Taking this ahead, if we speak in terms of diagnosis, children's diagnosis were classified as infections, fractures, wound injuries, or soft tissues or ligament muscle injuries. Now, what is the most common, children's diagnosis? 51% of children had soft tissues or ligament or muscle injuries, followed by fractures, infections, and wound injuries, right? Remember, we're talking about a situation, we're talking about an emergency room situation where we have kids who've been brought in due to these reasons, right? Taking this a step ahead, uh, let's take this ahead and discuss these results one by one, right? I have again put this into points over here so that you all uh, understand every single bit, and then this would of course help you with the learning process too. So if we speak in terms of pain assessment, doctors assess the mean level of pain through the NRS. NRS, remember my dear, is the numeric rating scale. This was 3.2. The parents assessment was higher as compared to the doctor. This was 4.8, right? And the children's own evaluation was highest at NRS, that is 5.5, right? So if you're talking about a comparison between this, and this, do you see that the child feels like the child is experiencing more pain than both the patient and the doctor think the child is experiencing, right? So one, the second point that has to be taken into account, differences in terms of assessment. On average, physicians assessed pain levels 2.3 points lower than the child's assessment. Physicians' assessment were 1.6 points lower than the parents' assessment as well. So if I talk in terms of ranking over here, children felt the pain the most. Parents thought that the pain wasn't as bad, and the physician, that is the doctor, falls into the third category over here. The physicians thought that the pain wasn't uh, as bad as the parents thought it was, or was not as bad as the child or the patient thought it was. If we speak in terms of age differences over here, remember this was another factor that was being catered to through the second aim, if you remember. So age differences, parents and doctors rated pain lower for younger children. There was little difference in pain ratings for children at different ages, but there was a greater difference between the children's assessment and that of the parents and physicians for younger children compared to older children. Now, these were results in terms of pain assessment. These were results in terms of differences in assessment. These were results in terms of age differences. Taking it a step further, if we speak in terms of agreement in pain assessment, parents and physicians had a low agreement, right? A low agreement in terms of it being painful. Children and physician also had low agreement. This was 14.6%. Agreement between the parents and children was higher, that is 40.1%. Now, if we talk about, see, we over here, we are making a comparison between parents and physicians, right? Over here, the second point, we're making comparison between children and physicians. The third point over here, we're talking about a comparison between parents and children, right? So agreement in terms of pain assessment. The next result, differences in assessment with pain severity. How severe is the pain? The difference in pain assessment between physician and children decreased with increasing pain severity. Now, the difference in pain assessment between the physician and the children decreased with increasing pain severity. Or, in other words, the more severe the pain got, the lesser the difference was in terms of assessing that it was actually painful by the physician and the children both, right? In other words, the more painful it is, the lesser chances there are that there would be a discrepancy or a difference between the levels of assessment that are made by the child, that is the patient, and the physician. The next one, mean differences in NRS. NRS, remember, is numeric rating scale. For mild pain was 3.2. Let me use different colors over here so that this helps you further ahead as well. So mean differences in NRS, it was 3.2 for mild pain, 1.2 for moderate pain, and 0.6 for severe pain. Sometimes physicians' estimates were higher than the child's assessment for severe pain as well. Now, taking this ahead, if we speak about the physician's perception of pain reaction, physician's perception of pain reaction. Now, the physician's assessments were influenced by whether they felt the child's pain reaction matched the medical condition. At times as a physician, you might feel like that the child is overreacting, right? So the physician's assessments were also influenced when they felt that the child's reaction did not really match to the medical condition they were in, right? So if I put it in a simple manner, if the physician feels like the child is over exaggerating, if not faking pain, then this would influence their assessment too. So taking this ahead, the mean difference in physician's assessment, mean difference in physician's assessment and the child's assessment was significantly lower. So this difference was lower when physicians felt the child's response was expected, right? So the difference was less when the physician felt that for this level of, for this particular medical condition, this would be, for this particular medical condition, this would be the expected response that a child would have, right? So the mean difference in physician's assessment and the child's assessment was significantly lower when the physician felt the child's response was as expected, compared to when concordance, or compared to when the expectation was lower, right? Now, taking this ahead, the factors that were not associated with pain assessment differences. Let's list them. Number one, mean waiting time for children. This did not affect the differences in terms of assessment. Number two, child's gender. Number three, physician's gender or experience, and whether the physician had their own children were not associated with differences in pain assessment. So if we list down the factors that did not affect the physician's assessment. Let me just put this like this. If I number them, number one, the mean waiting time of children. Number two, the child's gender. Number three, the physician's gender. Number four, the physician's experience. Number five, if the physician had his or her own children too. Taking these results further, if we move on and we speak about painkiller administration. Physicians gave painkillers to 8.6% of children, with these children having a mean numeric rating scale of 4.9 according to the physician's assessment. Painkillers were given to 4.1% of children with mild pain, 9% with moderate pain, and 42% with severe pain. So, as you see, the level of pain increases, so do medications, right? Now, like I said right at the beginning, it's pretty essential that the physician assesses or diagnoses the pain or the medical condition that the child is experiencing too well. Number three, however, only 14.3% of children with severe pain, as rated by themselves, received painkillers, right? So if you guys have a closer look at this, there is a difference, right? See, 14.3% of children with severe pain, as rated by themselves, received painkillers. Do you understand this? This is probably because when the children felt they were experiencing severe pain, probably the physician did not, probably the physician thought otherwise. The next point, underestimation of pain by physicians. Emergency department physicians significantly underestimate pain. Now, we could refer to this as the conclusive end to the study as well. So, emergency department physicians significantly underestimate pain compared to parents and children across all conditions and all ages, right? So, in other words, the extent to which physicians feel the child as a patient is experiencing pain is lesser than the assessment done by the patient's parent and the patient himself or herself. One. Number two, underestimation is likely to occur with fractures and with children aged 8 and over. So these were the two conditions where this underestimation was seen to be more. Now, I just tried to quickly walk you through this study that was conducted by the Norwegian medical doctor and professor uh, Christina Brudvik, right? Now, let me remind you all, it is pretty essential that the doctors or the physicians, they diagnose the pain condition of the patient well, because if they're not able to diagnose the medical condition or the pain condition that a patient is going through, a child specifically, especially is going through, that might result in a negative consequence. That might result in the child's healing process being delayed, the child's pain relief process being delayed, and moreover, a longer term impact, like I had mentioned right at the beginning, could be that the child are not feeling very good about or not wanting to come to the medical facility or the healthcare facility. Now, remember, this was just a quick little summary, and I would expect you all, I'd rather advise you all to study through the key study through your course book well, and having a look at the specimen paper, try to attempt questions that you think you could get on this particular study too. So this is pretty much it. Take good care of yourself. Stay happy, healthy, safe, and protected. Stay humble, spread positivity, spread smiles, and Allah Hafiz.